just to bring to your attention that we'll be working to a tack time of 20 minutes. So I had the opportunity and the privilege of being the co-lead for the team for RPIW 48, and this is our team. Jamal. And I'm Carolee Zorn. I'm a manager from the Sunrise Health Region. So our project was to improve patient care by eliminating inconsistencies in booking special diagnostic procedures from the physician's office. So this is our project form. We started out by looking at the process through the use of a value stream map. This is all pre-Kaizen, so this is before we made any changes. And what we found in the CT booking process was that we had a value add time of 10 minutes and 20 seconds and a non-value add time of 22 hours, 30 minutes. So 1% of value add and 99% of that process was non-value added to the patient. And also for special diagnostic procedures, we found we had two streams there, and we found in the top stream that we had value add of 81% and non-value add of 19%, and in the bottom stream we had value add of 24% and non-value add of 76%. So pre-Kaizen, the team sat down and we looked at the process, and this was all the waste or muda that we found in the process that we hope to address through the week. So our target progress report, to start off with, we looked at the DI imaging storage space off campus, and we found we wanted to reduce the space, or increase the space and decrease the inventory there by half. As far as in the department, we looked at walking distance and the part-time travel, and we both wanted to reduce those by 50%. We looked at the lead time for the from requisition to the appointment booked, and we wanted to decrease that by 50%. And then we looked at some quality issues, and we wanted to eliminate the inconsistency or the number of times that the recs arrived without the supporting information, and also the number of times there was miscommunication between the RAD and the unit assist. And we also wanted to eliminate the number of phone calls received to book special diagnostic procedures. We wanted to increase our productivity gain for CT scan booking, and we wanted to increase our capacity to book CT scans. And our talked, actually, because TAC is a German word and you need to have a in there. So our talk time was 18.8 minutes. We timed the cycles of work in the process, and this is a time observation form showing those timings. And then a visual representation of the pieces of work within the process minus the wait times. And this is a percent load chart that shows you in minutes the amount of time for each cycle. And then we also have another visual representation of the whole process with the standard work combination sheet. And the squiggly little lines are wait times. So that's where the 22 hours came from, was all that wait in that process. This is a spaghetti diagram sheet showing you the walk distance between the booking clerk's office and the RAD's office, and that was happening up to 3 or 4 times a day. And then Steve and I had the privilege of doing a 5S on the storage room, and our pre-5S score was 1, and our post-5S score was 2.9. The best it could have been was 3, so I thought we did pretty good. And then we have some pictures of that process. So this was pre-5S. You can see that the space was very well organized, and it contained a lot of unworking equipment and other pieces of inventory that had just been kind of shoved into that space. And then we also didn't have any labeling or organization going on there as well. And just whoever wanted to put something in there, they just did that. And so we had the opportunity to get rid of a lot of that Buddha from that storage space, and finally came up with a finished product. So you can see we eliminated a lot of that and increased the space. We labeled the shelves. We even saved the Christmas trees, because these were important things and we needed to save them, and we saved them. So there they are. They both have their space, and that's awesome. And we made a standard work in regards to maintaining that space the way it is now after the 5S. And we've created an audit tool for Kelly to follow so that she can audit that space and make sure that it's being kept orderly. And these are our PDCA cycle, our planning, do, act, check, and act cycles that we came up with after looking at the process of things that we wanted to try.
Hi there. My name is Carol Bell, and I'm one of the unit clerks in the medical imaging department and I've been chosen to participate in the RPIW number 48. I will be speaking about the division of the work duties between the unit clerks and creating the work standard. As seen in our idea summaries sheet, our observation recognized that there was no clear division in some of the work tasks, and it was somewhat of a muddled process. In discussion, it was felt that the solution would be to have clearly defined jobs, tasks between the unit clerks, thus generating more time to schedule and book all of the appointments. We divided the unit clerk's tasks into a booking desk and a reception desk task and created a work standard. Once this was created, our work standard was created, our team orientated the staff in medical imaging unit clerks, and we did this so that our manager could then implement the changes.
Hi, I'm Betty, and I'm an MOA from PA Medical Clinic, and I'm speaking on the appointment booking process. The problem, as on the idea summary sheet, was the physician's office phones the diagnostic imaging to book the fluoroscopy, ultrasound, and echo appointments, and the physician's office then would fax the requisitions. This differs from the CT appointments, which are faxed from physicians' offices, so there are two different standards. The solution, the physician's office faxes requisition for fluoroscopy, ultrasound, and echo, so now there is one standard. Before the improvement, there were too many phone calls, and after the improvement, there were less phone calls. The problem is on the next idea summary sheet. The patient doesn't have one point of contact to call to see if appointment has been booked. The solution, the patient will be told by the doctor's office that for the CTs, they should receive a letter in approximately 2 weeks. If they have not heard in that time, they can call the doctor's office to get the information, as the doctor's office will also have this booked information. Before the improvement, too many phone calls to diagnostic imaging, and the patient was not sure when he would hear about their appointment. After the improvement, there was less phone calls to diagnostic imaging, and the patient will be given more information as to when they will hear about their booked appointment. The work standard was then made, and this work standard was then taught to the diagnostic imaging unit clerks.
So good afternoon, everyone. My name is Penny Hope. I work in Human Resources at the Health Region here, and I'm a participant in RPIW 48. So this week we worked on clarifying some communication issues in the department that were affecting patient care. So the first problem that we worked on was the batching of CTs during the day. And so currently the process was that CTs would be faxed in throughout the day, and then they would be delivered to the radiologist at the end of the day. And then the radiologist at that point would prioritize them into the booking order that they needed to be in. So this resulted into sometimes up to a 24-hour delay, as the requisitions may not get back to the unit clerk for booking until the next morning. So one of the ideas was to deliver the requisitions more often throughout the day, and also to change who they were delivered to. So instead of taking them to the CT radiologist, we actually took them to the ultrasound radiologist. And the idea was just based on their workload, it worked better for them. So what we did is we set up an inbox and an outbox in the department, and we scheduled delivery of the recs throughout the day at 9, 11, and 2. And what this allowed was that the level 2 recs could be booked in a more timely manner throughout the day. And it also allowed the radiologists to work on that prioritization throughout their day as well. If they had a few minutes, then they could maybe do a few, versus at the end of the day when they had maybe 30 to go through. So the other area that we worked on was the communication for emergent CTs. So currently what the process would be is if a physician required an emergent CT, which is usually a same-day CT, they would call the radiologist and have that patient sent over to the office. So what would happen in the office is we'd have the patient show up, we wouldn't be aware of the patient coming, and it would result in the patient waiting, and then us having to go over to the radiologist to clarify why they were here, what's the protocol on them, that sort of thing. So one of the ideas that we tried this week is we set up an inbox or an email account for the radiologists, and we made a diagnostic imaging group that would receive that email. So when the radiologist was on the phone with the physician, they could just open their email, send a quick note to the group saying, this patient's coming over, name, physician, name, the physician, and then also maybe the protocol. And then that way the unit clerks receive the email and are aware when the patient is coming over. Patient doesn't have to wait, and we're also not interrupting the radiologist throughout the day. So for both of those processes, we also have work standards developed for everybody to follow.
Can I have your attention, please? The hospital fire alarm devices are being verified today. The audio alarms are disabled, as well the visual alarms are disabled.
Hi, I'm Dr. Harris. I'm a family physician. I'm involved in RPIW 48, which is booking CT scans, ultrasound, fluoroscopies, and echocardiograms from the physician offices. Just as a first comment, the diagnostic imaging is a very busy, high-pressure department. There's some 8,000 CT scans done in 1 year. They're very highly functioning. I think that was more due to the motivation of the employees there who kept it. So despite the fact they were being pulled in all kinds of directions, mostly by the telephone. So we worked together as a team, and we, I think, successfully kept the patient first, but we also were cognizant of impacts on diagnostic imaging and on physician offices as well. So my role, I think, we identified that physician offices would book a CT scan, as Carol pointed out, and the patient would say, well, when's my scan going to be? And the physician would shrug his shoulders and say, I don't know, phone diagnostic imaging and find out. And they would say, well, maybe phone your doctor and find out. Nobody knew. So it was actually a good solution, I think. So now when a CT scan is booked, a copy of the booking will go to the physician's office. So that would allow the patient to contact their physician to find out about when the scan is, or if they had any inquiries or any questions they needed to ask. Secondly, what we did was I personally spent a lot of my time developing a communique, a memo, I guess, that kind of outlined, and this I think has to be ratified fully, but just to go out to all physicians, just to point out that it's a new thing that they will get copies of when CT scans will be done, and also to reiterate the need for renal functions to be done with all CT bookings, because many of them will involve contrast down the road. So I think this I tested a bit at a Regional Medical Association meeting, and it was very well received, so I don't think there'll be any issues. It's a matter of getting this communicated to physicians. It's not any kind of a big change, and it was a welcome change. Finally, I'll just add that one more thing that we were able to accomplish that wasn't really on our agenda is in one of the inevitable downtimes, we did do a 5S on our little supply kit box. It had markers, erasers, staplers, staple removers, and so that was beautiful. We got that perfectly done. In the process, we came to the conclusion that these mechanical lead pencils, they're Muda.
Good afternoon. My name is Fred Barr, and I'm a patient family advisor. So as Dr. Harris was saying, that the problem was physician's office not aware of when booked appointments were. The proposed solution to that would be the that the physician's office would be notified of the bookings in the various categories. And an intended outcome is that the patient would be able to contact somebody. So from a patient's perspective, what it is that what is it that I need to know when I go to my doctor and he orders a test? Well, I need to know, why are you doing this test on me? And is it going to hurt, and stuff like that. The other aspect that I need to know, and the doctor can usually answer that. If not, then I'll probably be looking for another doctor. In other requirements for me are, where do I go, when do I go, and how long is it before I get looked after? It's reasonable then that the doctor can't answer that if he doesn't have the questions. So hence the solution to the problem is here. My hopes is that the letter that we will be getting is clear and concise so that I understand it. And it will not eliminate all the phone calls, it will reduce those phone calls. What I ask of you folks is that when we phone, don't consider that as an irritant. It is simply a request. We're anxious, we want to know, and we greatly would appreciate it. Also, keep that to yourself. Not everybody has to know that I was an irritant. Basically, that's it. And it's a degree of confidentiality for me too. So I enjoyed the process. Thank you.
Hi, I'm Steve Old with PAPHR. I'm a property manager. And I can't hold the papers and handle the mic, so I've got Vanna White here. Okay, so I'm doing the post-Kaizons. So how did we do in our whole project here? So I'm going to start by looking at our 7 wastes. Our 7 waste wall was cluttered with all sorts of things that we had happening. And just by addressing a few of these items on our committee, we were able to address just about all of our wastes, which I think was a success. The value stream map that we actually have 2 value stream maps, but you can see that we have also addressed the starbursts that are there. Our non-value added time was 22 hours, and we've now reduced that to 4 hours. Most of that time actually was captured all with just organizing the times that the radiologist prioritizes things. So our next value stream map actually shows the requisition always being faxed in instead of being phoned in. That hasn't started yet, but we're hoping that actually does happen really quickly, and it also is going to add a lot of value to the process. Our time observation form, this is post-Kaizen, of course. Actually, we decreased the amount of time that booking takes, and that actually was done just because we've reduced the amount of interruptions, and we've kind of standardized the workload. We've leveled the workload for them. The percent load chart does show exactly that. Our decrease in time actually happened mainly due to just not as many interruptions for the staff. Standard work combination sheet is actually a graph of that value stream map. And again, if we go to the very bottom of the chart, the weighting has now been decreased from 22 hours to 4 hours. So again, just a little tweak in the system made a big difference. Our spaghetti diagram takes numerous trips that the clerk used to do to the radiologist office. So all of a sudden, an email, and that is totally eliminated. So if we look at our target sheet post-Kaizen, we have the storage room. We decreased the amount of space by 67%. Our inventory, we decreased that by 97%. Our walking distance, again, by just an email going back and forth, we decreased that by 100%. Same as the park travel distance, 100% decrease. Our lead time went from 22 hours, 40 minutes, all the way down to 8 hours and 40 minutes. So that's a 62% decrease. Our quality actually shows that 32% But we haven't really started that process. So this quality measurement is just sort of a measurement of what's really happening right now. So as soon as that process gets started in there, we're hoping that that actually gets decreased as well. And we have the communication from the unit clerk to the radiologist. That again is 100% because we're just emailing that information. And our echoes booked per day, well, we're not really, that process hasn't started again. Lastly, I'll go to capacity, and our capacity should increase by 25% because we've got that little bit of extra time to be able to do those bookings. So our newspaper items, we had quite a few newspaper items, and luckily we were able to address just about all of them. The only thing that we don't have closed yet for newspaper items is will be handled by Dr. Harris's letter that he developed. So a good communication going out to everybody, and you'll notice that most of the work gets passed on to Jan and Corinne to finish off. No, we'll just point. Yeah. So lastly would be the workshop summary. So how did we do? We have better communication between the radiologist and the unit clerks. We have more frequently and scheduled prioritization of the CT requisitions. We have a successful division of tasks between the unit clerks, so a lot of load leveling I think happened there. And the elimination of phone calls for booked RF, ultrasound, and echo cases. So if we get, again, those are gone and now it's all faxed into us. And then the booking information is actually a key part to this. We now give the physician office good information so they can pass along to their patient if they get a phone call as well. So Fred.
I'm tasked with a lovely job at thanking folks. So on behalf of the team and especially us, the patients, I'd like to thank the radiologists, Drs. Lowe, Shavera, and Bugler, the medical imaging staff, in particular Nancy and Vanessa, who spent a lot of time with us and helped us out. The IT team, which gave us a lot of support, and a special thanks from me to Betty and to Dr. Harris, who came from the outside and did that kind of stuff. Plus, they entertained me. And then it says, you must all clap.